I'm very sorry, Professor Adnan. I appreciate your understanding, but
No,
it's a
please.
working day today, so.
Okay, please go ahead.
All right. I hope you see my screen right now.
Yeah.
So I'll be presenting about the ultrasound in neurosurgery. My field of specialty is actually pediatric neurosurgery. So a lot of understanding for the ultrasound in intraoperative in tumor excision, but also I'll go primarily with the physics of the ultrasound. So the ultrasound, basically, it's ultrasonic wave. It's a light wave. And the thing is, you put it in a direction, whether it's axial or coronal. It sends the pulse and it hits with the surface, give you the image. So it's according to how you place your transducer or your probe. It gives you the axial cut or a coronal cut according to how you place the probe in the first place. So as you can see here in this picture, it's an idea of how to see into the tumor. Another trick that I would like to use of how to use the probe is you could imagine that as if you're looking into the probe with your eyes. So if you put the probe in an axial cut, you would see in an axial section of the brain. So other than the neuro-oncology parts, that you can use. You could also use in babies when the fontanelles are not closed yet. So this is a very important thing to use while you monitor the ventricular size in hydrocephalic patients. And this is less radiation for them, especially when you need to do a lot of CT scans to keep them, to monitor them, other than the occipital frontal circumference. So ultrasound is a very safe instrument for the kids that has a lot of radiation. So intraoperatively, we use this kind of ultrasound, but regardless of the machine, it's how you understand the tools and how you understand how to use it. So we use two probes mainly. The first probe we use it for the brain tumors. The other one, which is the joystick, it's mainly used for the cavity inside the brain tumor or after resection, but we also use it in the spine tumor because it's a smaller size. It can fit in an axial section of on the spinal cord after you do the laminoplasty. So you can have two images here. One is the cranial part, and here's the spine. You could have an idea of the vertebrate body. So what's the actual benefits of the ultrasound when we use it in the intraoperative and neurosurgery and oncology surgery specifically? That's how I use it. So it gives you a very real image picture because sometimes in the navigation after you drain CSF or after you do tapping of a cyst, all the parameters changes. So sometimes navigation isn't very accurate. If you did this while using the navigation and you lost a lot of CSF, you could use the navigation only to point the bony marks, the bony landmarks that could give you an orientation. But ultrasound can give you a real-time image of the tumor, of the cyst, even after the shift, after CSF absorption or whatever you do. The other thing, it's actually a minimal invasive and it's cost effective. You know, the MRI intraoperative gives you an intraoperative image, but it needs a special equipment and a lot of things. Other than this, also, we can use it in tapping of cysts, in ventricular tapping of the ventricle. If you have like a craniotomy, you could use it to identify the anatomy and when to stop and when is the limits for you. And also an important thing is when you use as a Doppler, because a lot of tumors sometimes engulf a tumoral vessels or there's a major vessels around it, so you can use it. The other thing is sometimes you have a complication intraoperative, whether it's a subdural hematoma or apoplexy in the tumor. You could actually see this on the meantime by the ultrasound, which is very helpful. So those are like pictures I want to share, like this posterior fossa ependymoma. You could see from putting that probe in an axial. It's not a perfect axial, and the posterior fossa is a little bit oblique, but it gives you an idea of the tumor, and you could see the cerebellar hemisphere both sides. This one is neurocytoma, and you could see here, this is a video of the ultrasound. You could see the interhemispheric fissure, and you could see the two lateral ventricle and the tumor. This one is, we use it for assist tapping. So you could see here applying the probe all the way and have to tap the cyst. Sometimes you have a very big brain tension or huge brain tension. You need to decrease the tension before you start working. So as we said, we could use it also for the brain Doppler. You could see here the vessel by the medial base of the tumor. Also, this is you could see the maximum site of resection. So the thing is about ultrasound, it needs a lot of time to get along with the picture of the ultrasound. So this is post-resection. You can see here the edematous layer post-excision. This is basically an edematous layer. It's not the tumor. You could visualize this more when you see the preoperative before the excision and post-excision. So here you can see the edematous layer, and you can know that there is no residual left. For instance, here this was a meningioma. It looks a little bit intraaxial, but it is not. So you can see here the tumor is the yellow star and the artery. And here you can see the blue star, which resembles the sylvian fissure. So the more you understand the anatomy, the ultrasound gives you an idea of where to stop and where you're at. You could also here see the two lateral ventricles and the choroid plexus in one of the ventricles here, and the tumor. So the more you get to understand the use of the ultrasound, how you see it intraoperatively, it guides you a lot in the anatomy and complication. So this one is the tumor here, and you can see here the resection body after it. This is after application of Surgicel or Fibrillar, according to what you use. It sometimes gives you an artifact. So you'd rather use this before putting the hemostatic agent that you would use. The future use of ultrasound is when you use it guided with navigation. So it's navigation guided ultrasound. So it gives you an idea of where you are from the navigation picture of the MRI. Sometimes it's very clear and gives you a real-time image on top of it. So you can see here in the last images, the cavity of the tumor is resected, while you could see the rest of the tumor is actually there. So this is two pictures. One is before the Surgicel, and on the right one is after the Surgicel. You could see the artifacts. Here you could see the cavity, the tent, the lateral ventricle, and even the choroid plexus. But the limitation, it's you need the operator dependent, limited penetration. You can only use like 6 centimeters or something, and interpretation variation of the ultrasound. Thank you. And thanks again, Professor Adnan, and thank you for shifting the schedule. I appreciate it.